Hello and welcome to the final day of Migraine and Headache Awareness Week. Today's session is a events highlight and also an opportunity to have a general Q&A. Next up, quickly, our mission. So Migraine and Headache Australia is a division of the Brain Foundation. Our mission is threefold. It's to provide trustworthy and reliable information, to fund research into migraine and headache disorders, and also to provide support and advocate for people living with migraine and headache diseases. Next up, for the final time, we are highlighting an advocacy or media highlight from the past 6 months. And today we are looking at these two in the top left. So this was the Parliamentary Friends of Dementia event, which was in Canberra earlier this year. It was hosted by Dementia Australia, and we attended. That you'll see here, Carl and Trevor, with our Brain Foundation ambassador, Brett Carney, who's an ex-rugby league player. And this was basically, we also had Wally Lewis, who is an advocate for CTE awareness, and he spoke about the impact of CTE and sport on his life. And it was a great opportunity to raise awareness for the impacts of repeated concussions or head injuries, and ranging from everything from headache and migraine all the way up to, diseases like CTE, which is a type of dementia. And next, I also wanted to point out our advocacy toolkit. I've spoken about this every other day this week, but just a last reminder, it's basically a guide on how to get in touch with your local MP or speak to a journalist. There's some great resources, and also background information on like our mission and tips on, how to, I guess, like showcase the impact of migraine. But, telling your story is such a wonderful thing you can do for the community. And yeah, the link is there if you're interested. Now, I'd also like to thank our event sponsors, AbbVie, the Brain Foundation, Pfizer, and Lundbeck, especially on the last day. This has been such an incredible week. I'm sure that all of you have also been enjoying the presentations. I know I've learned a lot. It's been fascinating so far. So thank you so much to our sponsors for your support of this event. Next up, who is this for? You are in the right place if you have a migraine or headache disorder, or your a friend or loved one has a migraine or headache disorder, if you want to connect with others, and most importantly for today's session, if you want to ask a question. Hopefully we'll get through some of those that we didn't get to early in the week. Next, I just wanted to highlight our support group. As I've said in other sessions, this is a really welcoming community. If you're on Facebook, I can't recommend it highly enough. I know Facebook isn't for everyone, but if you are, it's a wonderful community to talk about, shared experiences, and we would love to have you there. Now, I'd like to introduce our expert for today, Professor Tissa Wijeratne. Professor Wijeratne serves as the chair of the Department of Neurology at Western Health in Melbourne, and he's the co-founder and chair of World Brain Day, which is on July 22nd. And it's a really successful initiative to bring brain health into a global focus and make it, a household discussion. Brain health is so important, and it's a fantastic achievement of Professor Wijeratne's. He is also Australia's most cited practicing headache specialist. And if you're not reading academic journals often, you might be wondering what that means, but that essentially means that out of his 356 publications, they are incredibly highly referenced by other researchers and scientific authors. So lots of people have, used his work to inform their own, which is a massive achievement. And he's also this is particularly noteworthy given his background as a specialist neurologist from a culturally and linguistically diverse community. And he is looking after supervising 12 PhD students at the moment. He is also the president of the Asian Regional Consortium of Headache and the global chair for migraine and headache disorders at the World Federation for Neurorehabilitation. So a lot there on that slide, but we are so lucky to have him here today. He's truly a leader in the field of migraine and headache disorders. So thank you, Dr. Wijeratne, for being here. Now, quickly, just a bit about me. My name is Anit Grundy, and I'm the grants manager and digital lead here. And I write a lot of our website articles, newsletters, and look after the admin side of our grants program, which basically is, processing the incoming applications and liaising with the scientific committee. Now I just wanted to get into the, sorry, Dr. Wijeratne, we're just a bit early for the Q&A. I'm just going to do the recap of the event first. Okay, see you on the other side. Sorry. So excitingly, we already have all of the webinar recordings so far up on the website. So you can access them from the main event page. So if there's anything that you missed or wanted to revisit, they're all there, which is great. Now, on Monday, we had Dr. Jason Ray and Dr. Emma Foster speaking about new treatments and research. I know there's a huge amount of text on these slides. I'm not going to read it all word for word, or we'll be here all day. But we will be recording this webinar, and if people are interested, we can also make these slides available as kind of like a take-home summary of the talks. But a couple of things that stood out to me in this presentation were firstly the AHEAD study, which Dr. Foster worked on and spoke about. This was essentially seeking to establish how many people have migraine in Australia and what's the impact, because at the moment, all of our estimates are based on overseas data. Unfortunately, the pilot study didn't have a great response through sending out a mail-out survey. However, this showed that there's like a real case to include it in the census. So they're in conversations with the ABS about adding it to the census, which would be a huge win for the migraine community. So hopefully, I'm looking forward to seeing how that pans out. Another exciting update from this presentation was the discussion of how Ajovy is now available for people with high frequency episodic migraine, which is anyone who has between 8 to 14 headache days per month. Research shows that this has way more in common with chronic migraine than low frequency episodic migraine. And while obviously, like, even if you're having 4 attacks a month, that can still be a huge impact on your life. That's every single week. But this expanded access sets a great precedent for improved access across the board in migraine treatment. Next up, Dr. Ray highlighted some of the exciting new research that's come out recently. Essentially, really quickly, one study that was looking at Vyepti and its long-term efficacy, it essentially showed that yes, just as with the other CGRPs, it does continue to be effective in most people. You don't have that tapering off where it stops being effective. Of course, some people may experience that, but it looks quite good. Another great finding was that similar to triptans, if you switch from one CGRP to another, for example, if you don't respond to Vyepti and then you go on to try Ajovy, you may find that Ajovy is effective for you. So that's great to know that if you don't respond to one, it doesn't mean that you just shouldn't try the whole class. Like, there is a good reason to switch treatments. And then also the research about relapse after stopping CGRPs. This study found that people who stopped taking CGRPs after 12 months, about 30% would relapse back into their previous headache pattern. However, when you moved that out to 24 months, only about 12% of people relapsed. So this was a great finding for long-term treatment. And then there's also, of course, the GPANTs, which are an emerging new medication, and we hope to see one of them on the PBS soon. And Dr. Ray also covered PACAP, which is a new target for treatment, which is currently in development, and it's not close to being ready, but it's on the horizon. And so we're looking forward to receiving continual updates about this medication. Next, on Tuesday night, we had Dr. Elspeth Hutton speaking about chronic migraine. And this was a really well-rounded presentation that covered everything from basically what is chronic migraine through biology, different treatment approaches, lifestyle management, and even chronic migraine reversion. One thing that stood out to me about this presentation was really that reversibility of chronic migraine. I know when you're like in the cycle of those chronic migraine attacks, it can feel like you're going to be trapped in that cycle forever, and it can feel really hard to take on. But there has been research showing that, yeah, like while the brain of a person with migraine is structurally different, there are like real biological changes. And it shouldn't be treated lightly or as just a headache, as so many people write it off. However, with the correct treatment, lifestyle management, prevention, a great healthcare team, it can be reversed, and those changes in the brain also will reverse with the lowered migraine frequency. So I thought that was a really like wonderful take-home point from her presentation. And Dr. Hutton also, if you want to go back and watch that recording, she spoke about some wonderful considerations in like how doctors approach preventive treatment, how to select the right acute medications, and some great information about the biological underpinnings of lifestyle change. Because while it might sound really frustrating, and when, a well-meaning friend might say, "Oh, you've got migraine, have you tried meditating?" And yes, it sounds ridiculous, and there does need to be proper preventive and acute treatments. But there is biological underpinning for these lifestyle changes, or basically non-pharmaceutical recommendations. Next up on Wednesday morning, we had Professor Dawn Buse speaking about mental health and chronic pain. This was a fantastic presentation. Dr. Buse spoke a lot about the variety of comorbidities that migraine has. And obviously she was focusing on psychiatric comorbidities with mental health, anxiety, depression. But there was an interesting point in the Q&A where someone asked, why does migraine have all of these comorbidities, and what do you think is going on there? And she presented an interesting theory that it could possibly be due to just general inflammation in the body, and due to stress, our modern diets, and I thought that was an interesting approach towards understanding migraine. She also had some wonderful advice about how to manage mental health with chronic painful conditions. Obviously, this was about migraine, but if you're living with other conditions that cause chronic pain, so arthritis or fibromyalgia, this advice is also helpful for that. Just the importance of support, the importance of being kind to yourself. I know it's advice that people may have heard many times before, but it really does make a significant difference in balancing mental health while living with one of these diseases. And of course, the importance of seeing a psychologist or calling a helpline if you're really struggling with anxiety, depression, or suicidal thoughts. It's really important to seek professional help. These resources are out there, and please use them if you need to. Next, on Wednesday night, we had Dr. Michael Ellis speaking about side effects of medications. I know that there was a lot of complicated terminology in this for some people, so I'm sorry about that. I have included, where possible, the brand names of the medications on this slide, which will hopefully help with, if you do go back and rewatch that presentation. I won't go through every side effect listed on this slide, but Dr. Ella moves through them all quite quickly. So if you do want to go and revisit that recording, I'd recommend you to. But in general, it was interesting to learn about the balance of side effects and efficacy. There are so many factors that affect the side effects that a drug may cause. They all have different safety profiles, different side effects, interactions with other medications, interactions with other conditions you may have. And I thought it was great how he talked about that holistic approach to recommending a drug for someone. And you can speak to your doctor about finding the right balance for you. It's a complicated process, but it is possible to find something, hopefully, that works for you. Another interesting highlight from this presentation during the Q&A was a couple of people were asking about some of the more theoretical concerns about CGRPs or other medications. And Dr. Ella spoke about the importance of not writing off these concerns entirely, while there might not be, some of them, there isn't like research showing, oh yes, like this is definitely a side effect. However, it's important to speak to your doctor about like everything that you might be concerned about. And like don't feel as though you need to be, not talk about something because it's like, oh, well, it's not that common or anything. Like just ask. And it's always better to ask and have an open and honest conversation about the risks of side effects. And everyone will basically feel more comfortable with the entire process. So I thought that was some great advice from Dr. Ella. And lastly, last night we had Dr. Catherine Spira speaking about other types of disabling headache, so non-migraine headaches. There are over 400 different headache types, so it's a lot for a headache specialist. However, they are classified in the International Classification of Headache Disorders, which is a fantastic resource. And essentially, headache types are split into primary headaches, which is migraine, tension type headache, neuralgias, and trigeminal autonomic cephalgias, which are on the slide there. And these are headaches that happen just because, like, they're a disease in their own right. And she also spoke about secondary headaches. And I thought this was a really interesting and helpful thing to discuss, because secondary headaches are caused by an underlying condition. So it could be anything from just you've had neck strain because you've been in an uncomfortable position at work, all the way through to something really serious like a tumor or stroke. And so in her presentation, she spoke about the 8 or 9 features that that neurologists use to exclude dangerous diseases, and that's summarized in the acronym SNOOP with 4 Ps. And some of these, one of the most urgent ones to highlight is onset, which is a really sudden onset, a thunderclap headache. It's, even if you have had incredibly severe headaches, this will be unlike anything else. And if you do experience anything like this, it's important to go to emergency immediately because it could be a sign of bleeding in the brain. And Dr. Spira also covered some of the neuralgias and I thought the underlying causes, and speaking about the biology between neuralgias and also the trigeminal autonomic cephalgias, such as cluster headache, was incredibly interesting. Anyway, I will wrap up the event recap and highlights there so that we can get into the Q&A. And Tissa, if you'd like to come back on now, it'd be great if we can get into some of these questions. Everyone, please keep submitting questions and upvoting as we go, and we'll try and get to as many of them as possible. So the top question at the moment, Dr. Wijeratne, is how much does inflammation play a role in migraine and headache? And since things like eczema, hay fever, asthma are comorbidities, would something like antihistamines help for migraine?
That is a great question. Can you all hear me all right?
I can. If anyone is having issues, yep. Oh, wonderful. Thank you for those.
Excellent. So let me begin by saying Ayubowan. That's from my original Sri Lankan language, wishing you wellness and long life. I myself is a migraine sufferer, so the first and foremost, don't ever lose hope. This is a disorder that we can completely control, believe it or not. And we have a long way to go, but together we can achieve this during our lifetime. So coming back to this question, this had been a research interest of mine for a long period of time. Some of you might have seen some of the published work that we have done looking at the behavior of white cell count parameters at different times, and there is a PhD that is happening on this topic also. To summarize the role of inflammation and migraine in particular, we all know that migraine is regarded as a disorder that is related to what is known as neurogenic inflammation. But it seems to be that there is a subset of migraine patients who does have a systemic inflammatory response also. Initially, I thought that this is something that I would see in those patients who come and see us in emergency department and with acute exacerbation of headaches. But currently, with unpublished work and not totally fully analyzed data, it seems to be that there is a subset of migraine patients who seems to have a chronic low-grade maladapted immune inflammatory response. We still don't know which one is the chicken, which one is the egg, whether it is the underlying untreated anxiety that is driving this, or the anticipatory anxiety of next headache. One of the main problem for me is some weekends it is hard to get my head away that whether Monday I would wake up with a headache or not, as Monday is a full day for me normally. I try my level best to eradicate that, but sometimes I fail, just being human. So that's that aspect. Coming to your question, the exact relationship with other known autoimmune disorders such as eczema, lupus, etc., I don't think we know the answer. Unfortunately, despite we being a rich country, our research portfolio in migraine is terrible. You can see that if I become the highest cited headache research in Australia, we have a long way to go, as you can see. So I strongly encourage you to keep an eye on research interest, especially coming from the universities and PhD students, and be part of that. We have to unravel this secret. Given that our world is in such a kerfuffle at the moment, countries like Australia must do a lot more than what we are doing at the moment. So
Definitely. Yeah.
I hope I answered the question. It is a story that has not been completely realized yet, but I personally believe that there's a lot of value for money in this area that we need to work on. And I got a couple of PhD students working on them. So hopefully, not only they would try and answer this question, and when my time comes to depart from this planet, they would carry on the flag and take Australia with the rest of the other folks in the world in the global front of better headache care.
Yeah. No, that's really well said, Dr. Wijeratne. Thank you. I'll keep an eye on the research updates on LinkedIn and all the journals and everything. The next question is from Serena. And she asks, she's heard migraine in the past being referred to as a vascular issue. However, this week, speakers have focused on nerve issues. Is there any truth in the vascular theory? And if so, what vascular issues can cause migraine?
That is also a great question. I remember attending I think, International Headache Academy a few years back, during my much junior times, and seeing some of the big guns debating on either side of the room. One group completely discarding vascular theory, and the other group completely embracing vascular theory. So I'm assuming that some of the speakers that you heard were proponent of non-vascular theory. I think it is a combination of both. I don't think we can completely discard vascular theory in migraine fully. Again, apologies for not giving you direct black and white answers. Again, this is a story that we haven't answered to the satisfaction of my curiosity, at least. But I would like to say that there is a significant vascular component. There is a significant sensory gain component also. But you don't need to be a rocket scientist to understand this. You see, human brain consists of about 100 billion biological electrical wires that are known as neurons, and they talk to each other with about 10 trillion synapses, and these synapses talk to each other through chemical waves. Obviously, we, this simple two-legged animal from cave days to come to thus far to control the world and to the extent even converting pages to bombs, sadly, you can see that for better or worse, how clever our brains are, how much thinking that we can do. Obviously, this need a lot of nutrition to be supplied. Also, that nutrition comes from blood vessels. And also, brain doesn't have a mechanism to get rid of waste products like our arms, legs, and other organs. We don't have a lymphatic system in the brain to get rid of the waste product. Only in recent times we realized that there is a system called lymphatic system that works only during sleep. So all these things would suddenly make sense to you then, that you cannot have a complex brain disorder such as migraine that we can put into a little black box saying that there is nothing vascular here. This is completely not vascular. While I don't know the exact vascular mechanisms to answer you at this point of time, I am of the firm belief that it is a multifactorial etiology, and I don't think that we can completely discard vascular theory totally. So there is a significant vascular contribution also. But I also, with all due credit to the other speakers, there's obviously significant sensory gain also. So there's a lot of electrical and chemical theories as well. We need to unravel these mysteries to fix this, hopefully during our lifetime.
Yeah, definitely. I mean, I guess that speaks to like the multifaceted nature of migraine itself. Like everyone has different, symptoms or different types of aura, and there's so much variation within it. It would almost be like oversimplistic to think it's just one thing causing it, I guess. Yeah.
And also the on top of this question, the one of the most curious things that myself and my fellow researchers split our hair on at the moment while supporting our PhD students is why we are seeing a lot of post-menopausal women and also reasonable number of old men with slightly different phenotype of migraine. This is completely unrecognized by wider migraine community globally. We have started writing about this in recent times. You can see them on PubMed and other things. I'll have a book chapter on one of Peter Goldesby's book in the coming months also on this. One of the curious thing that we haven't found a correct answer to that is why these folks experience a lot more aura and a lot more different phenotype of aura than what we normally see. I think there's a significant vascular component here, but we need to study these patients meticulously and carefully to unravel the mysteries. So that aspect is completely not done also. So just keep an eye on that and get involved in all these activities so that we can find correct answers to these issues. This episode is absolutely fascinating. I almost get fed up when I see younger neurologists and younger physicians not interested in this field and not interested in doing research into this field.
Yeah, definitely. Thank you for that. The next question is from Marianne. And she asks, if all triptans are fundamentally the same and all GPANTs or CGRPs are fundamentally the same, why is it worth changing to another on the same line if one isn't working? How does that variation work?
Oh, this is a great question. This question I can answer the fully. All triptans are not the same, first thing to say. And all GPANTs are not the same also. And also don't forget that although we have a tax file number and big ego and most of our human beings live life as if they're going to be here forever, we are completely changing dynamics. Say, for an example, you and me, who sat in front of the two computer screens 15 minutes ago, would have had 10 million changes happen to our molecular systems at cellular level by now. So really, we should not have any ego, to tell you the truth. There's no self among us, although we call ourselves selves. So as you can see from all 3 points, well, all triptans are not the same. Say, for an example, some triptans act super fast. I tell my patients who tell me that they have an acute headache that build into maximum severity within half an hour, I particularly choose a rapid acting triptan. On the other hand, I have some of my patients who tells me, including myself, we develop our maximum severity of headache over number of hours. So there's not much point us taking a super fast acting triptan. It is much better to take a slightly long acting triptan that can still do the job. And then there are other triptans that use your nasal blood vessels or blood vessels in the mouth to get into the system or get into your body. There are other triptans that use your stomach to get into the body. So if you are a patient who get a lot of nausea with your acute headache, there's no point taking the most expensive triptan that take your stomach as the vehicle to get into your body. You need to choose a different route medication. So as you can see, not all triptans are the same. Some triptans are super strong, some triptans are not that strong, some triptans act super fast, some triptans act much more it takes much more longer time to act. Japans, I only have experience with one Japant, but they are not the same either. It's like CGRP medications. It's pretty much like when you are treated by two different neurologists. Sometimes there is a subtle differences between one versus the other because we all learn from our patients. I'm one of the first botulinum toxin injectors in Australia, although I look young. I'm not that young, and the injection paradigm that I use 15, 16 years ago has changed a lot, having learned a lot from the patient that I have been treating. Despite most patients pay us to see us in our private sector, we actually learn from them a lot. My patients know that. I sometimes tell them that, well, I learned about this over-the-counter medication from two of my postdoc patients. While there are no research, you can give it a try. There's nothing to lose. I studied the chemicals. It's pretty harmless. So as you can see, not all these medications are the same. And also remember that just because you didn't respond to a particular triptan in 2019, that doesn't mean that you are going to fail in the same miserable way today. You are a completely different animal today compared to a few years ago. So unless you had a serious side effect, don't ever lose hope on any medication.
Yeah, that's very well said. Thank you. The next question is from David, and he's asking, assuming that there is a close link between the brain and the gut, what strategies, for example, specific diets, can we apply to improving our gut microbiome to reduce the incidence of migraine or headache?
David, that is a terrific question also. Again, I cannot answer you with wholehearted scientific truth as there's a lot of work need to be done in this area. But let's unpack the issue with our gut and general brain health before we come to migraine. Even thousands of years ago, if you look at Eastern philosophy or Greek philosophy, humankind knew that how we use our mouth matters a lot. What we put inside and what we put outside using our mouth make our health the better or worse. So the humans knew that what we eat make us who we are. And I would like to add how we use our mouth to communicate with others also make similar issues as we knew at that time and as we know now. So my advice with regard to diet is there are reports and research papers supporting all kind of diets that are out there. If you Google what is the best diet for migraine, you would see a whole lot of hits in them. So the first place to start is having small, frequent, healthy meals regularly. Your brain needs glucose. That's where I start when I start manipulating diet. Remember that there are a lot of other myths about diet and migraine also. I am yet to see a migraine patient of mine that I could fix by stopping them eating from chocolate or eating cheese or having red wine and then stopping migraine. So I don't believe that 99.999% of the time this food has got anything to do with why we get migraine. Having said that, there's renewed interest on gut microbiome and neurological disorders in particular. And we all know that migraine is the leading cause of disability in Australia among neurological disorders. It is the leading cause of neurological disorder worldwide among people who are under 50 years of age. And it is the leading cause of disability among all women all over the world, despite it continue to be the most neglected, worst managed, most pushed under the carpet neurological disorder worldwide, including Australia, sadly. So there's a lot of value in studying gut microbiome and the migraine pathophysiology. But at this point of time, I don't think we have enough evidence to say that I could confidently recommend a particular dietary pattern. I would start with a simple, healthy meal, small quantities frequently to avoid hypoglycemia and avoid high sugar content and avoid body weight getting higher and avoid the abdominal circumference getting bigger. In fact, recently I approved one of the manuscript that should get published in the highest impact factor headache journal, where the usual healthy food that are healthy for your heart and healthy for your brain is actually reducing migraines also.
Yeah, there's so much interconnectedness when it comes to like the brain and the whole body. Like I know I did a webinar for Brain Awareness Week earlier this year, and one thing that the speaker said that stuck with me was brain health is whole body health. Like, it's all, the blood vessels go everywhere, and it's all very interconnected.
100%. And for those of our friends who are out there practicing variety of dietary habits, from this diet to that diet to the other diet, if that help you with your headaches, it's perfectly all right. But make sure that you do that with proper medical advice. And if you have access to good dietitian, use them also.
Yeah, no, definitely. That's great. Thank you. The next question is from Linda, asking, has it been shown that taking supplemental magnesium can be of assistance? She also asks about hydration. I'm not sure if she just means generally just staying hydrated or like electrolyte, drinks that help with hydration. But yeah.
So the answer is yes. Basically, that's a great question also, Linda. Thank you for asking that question. Migraine, like all other brain disorders, because our brains basically make who we are. We are absolutely nothing without our brains. Brain health is the most supreme wealth. That said, when it comes to brain disorders, it is always good to have a holistic approach to how we take care of ourselves. So lifestyle, as you heard from Elspeth previously in the week, and probably from Dawn Buse, my friend also. And then over-the-counter medication, there's a series of over-the-counter medications that has been shown beneficial for migraine prevention also. Magnesium in particular has about 150 beneficial effects in overall brain health. You cannot become toxic with magnesium, as you can check your magnesium level every now and then in a laboratory. It's a Medicare-funded blood test in Australia, I believe. And then the prescription medications rationally on the advice of your the physician, your family doctor, as well as your neurologist. So magnesium, vitamin B2, feverfew, butterbur, melatonin. There are about 7 or 8 over-the-counter medications that at least have 1 or 2 research papers supporting their beneficial effect, and more coming on board also. I would suggest that if you're using an over-the-counter medication, just be informed what's the beneficial dose, and I wouldn't take any more than 2 of them, because there are no research papers supporting that taking 5 or 6 supplements are going to be helpful for you compared to 2, if that makes sense. So I do take magnesium from time to time for my migraine preventative, the armamentarium, depending on how my body and brain behave. I cannot take any more than 500 milligram. I get loose bowel motions, but some of my patients can tolerate up to 1 gram. So just be cautious that supplements are not completely nil side effects also. They are also chemicals, so just be cautious when you take them. But the supplements do have a role in migraine prevention. And lifestyle, I know that you heard from Elspeth. They just remember the word seeds. SEEDS. S stands for sleep, E for exercise, second E for eat and drink healthy, D for diary, to understand that you talk to your GP and your neurologist with a specific language of crystal clear days, headache days, acute medication days, etc. And last one is stress. While stress is not the cause of migraine, positive stress management always help to reduce number of attacks. If you practice seeds well, you produce what is known as DOS, the happy chemicals in the brain, dopamine, oxytocin, serotonin, and endorphin. So to have a good dose of DOS, practice seeds and use the supplements rationally and cautiously.
Those are great acronyms. I love that. Thank you. The next question is from Serena, and she's asking what your thoughts are on acupuncture for relieving migraine. Are there any risks involved? And is there any kind of research into acupuncture for migraine?
The acupuncture, yes, there is research support for acupuncture. Up until recently, we were basically saying that there's no evidence-based to support acupuncture. But even at that time, I did support some of my patients if they choose to go ahead with it. Risk of acupuncture is basically as long as the acupuncturist practicing the aseptic non-touch technique and not sharing needles, etc., all those infection prevention protocols are well taken care of, other than discomfort and potential for infection introduction. It's relatively risk-free. And there was a recent report that is indeed supporting some evidence base. Not huge, but some evidence base. Because migraine is such a disabling disorder, I think any complementary therapy that you can try, as long as they are reasonably harmless and not too expensive and you can manage them, go for them. This include gentle massage therapy to your head and neck muscles, although there's no evidence base to support that. If that help you to get by and make things better and avoid medication overusage, use them. So I am a supporter of all complementary therapies, including acupuncture. I don't necessarily go and recommend them heavily, but when my patients bring them to the table, I do work with them and I encourage them to use them. Because eventually what we want is as many headache-free days as possible and get our life back.
Yeah, no, of course, definitely. Thank you. The next question is from Kelly, and she asks about the long-term effects or side effects of Vyepti infusions and Botox injections. She's been having both for the past 12 months and just wondering about the side effects, both immediate and long-term.
So my experience with Vyepti is only a couple of years. I haven't seen long-term side effects among my patient cohort, and I haven't seen anything nasty in the literature that I read also. Botulinum toxin, I have more than 15 years experience. The long-term side effects of botulinum toxin is you can get thinning of muscles in your temporalis area in particular, because that area the target, sometimes neck muscles also. Hair loss also more frequently seen, not commonly, but you see that when you keep on injecting your patients for a couple of years' time. Believe it or not, some of my patients continue to have botulinum toxin years down the track, despite those side effects, stating that it had helped them to control their headaches significantly. Other than that, I haven't seen any serious side effects from botulinum toxin. Vyepti long-term side effects, I think we are too early to comment on that.
Yeah. If you did want to hear more about that, Kelly, there was a little bit of discussion about that in Wednesday night's session with Dr. Michael Eller. So yeah, that might provide a bit more clarity around those side effects. The next question is from an anonymous person, and they're asking, is there a correlation between toothache on one side of the face, on both the upper and lower teeth, with neck problems? And is this migraine or tension headache? There's no sign of cavity. Could this be some kind of like headache or facial pain? But yeah, I'm not sure about that one.
It's a difficult question to answer. Normally, I spend about 45 minutes to 1 hour with my headache consults initially, and sometimes I still can't figure it out, believe it or not, until I see them for the second time. So the try to give a sort of generic answer to differentiate tension type headaches from migraine, if you like, and other primary headaches which are categorized as trigeminal autonomic cephalalgias or side-locked facial pain, if you like. Migraine is a multi-system sort of a disorder with multiple phases. So it's like when you see horses in all those Melbourne Cup carnival and similar sort of a festival type horses versus when you move to really rural Australian cities and when you see wild horses. So the wild horses, although they look great, they don't have too many features as per the horses that you see in a sort of Melbourne Cup day like day. So the Melbourne Cup horses, they're sort of well dressed and sort of there's a whole lot of other things that are ongoing with them. So similarly, migraine has a lot of features. You have a prodrome, you have an aura 15% of the time, then you have an acute attack, and then you have a postdrome. You have a myriad of symptoms that if you Google multiple phases of migraine or multiple phases of migraine, you would see million hits with a whole lot of cartoons and pictures describing the symptoms, which are still the tip of the iceberg in my view. Whereas tension type headache, it's like those wild horses, not many features. No one is interested in them. It's a sort of dull, short-lasting pain that most folks wouldn't even bother to talk to their doctors about. The side-locked facial pain, they have typical features. Just to make our life a little bit difficult, some of them do have migraine-type features also. So to answer your specific question, somebody needs to dissect all these things and spend a little bit of time dissecting the clinical history and other phenotype to unpack this. This question is a great example for my colleague neurologists in Australia and overseas who believe that headache medicine is easy and headache medicine is not for the neurologists who are super clever. The headache medicine is difficult. I was trained in movement disorders and I'd done my PhD in stroke, but I found sorting out headache disorders are one of the most incredibly difficult, yet one of the most rewarding things that I have encountered over the years. I love all my patients, whether they have Parkinson's disease or stroke. I take great pride trying to help them one at a time. But what I learned over the years in headache medicine is that while they are very difficult to unpack and sort out, once you sort them out and unpack, you give their life back. You give the entire family the life back. And it is such a rewarding experience that you can never put a price tag to.
Yeah, no, that's incredible. That's such a fantastic way to, I guess, like understand headache and headache treatment. Thank you. The next question is from Trisha, and she asks if there's a contributory effect, stumbling, from Ehlers-Danlos syndrome.
This is a fantastic question again. The short answer is yes. Not only Ehlers-Danlos syndrome, but the syndrome that is known as postural orthostatic tachycardia syndrome. I saw another question asking about hemifacial spasm. There wasn't a question about arm tremor and cervical dystonia. I think up to 5 to 10% of my migraine cohort, which is good few thousand patients, really hardcore, difficult patients who had been to a number of neurologists before they came to see me, a significant chunk of them have all these comorbidities. And also the fibromyalgia, then chronic endometriosis. All these things seems to be comorbid disorders with migraine in particular. To the extent, if I say to the audience, there isn't a medical disorder that is known to mankind or womankind for that matter, or all other kind, that is not going to be a comorbid disorder with migraine, that would still be true. So you can see that the why I'm quite annoyed at a country like Australia, where we are supposed to be one of the best nations in the world, yet we invest very little on headache research, and we have not done really fabulous game-changing headache research and put us on the global map, yet is disappointing and depressing. And the only way to change that is by getting our patients on board and then encouraging our parliaments and others and forcing our universities to recognize this as a legitimate chronic complex brain disorder that is linked with depression, anxiety, suicide. If you really care about these things, if you really wanted to build a healthy nation, this is a disorder that you need to really recognize and support us to try and fix this mess that would have a huge impact for over 2.5 billion people worldwide. I think time is now, and we must get this job done and encourage younger doctors and
I'm not
other
sure if it's
healthcare colleagues to join the bandwagon and the support this mission.
Sorry, Tissa. I think my internet had a bit of a moment fritzing out for a second. Sorry about that.
It's okay.
Thank you so much for your response though, and it is so important. I really hope that we do see improvements in headache research in Australia. The next question, it might be the last one that we have time for, but it's from someone who wants to know, what medications do you consider safe for pregnancy and what must absolutely be avoided? I know testing medications in people who are pregnant is obviously not easy to do. So what's the research they're showing?
Well, I looked after a large number of pregnant ladies with migraine, and they all know the answer to this question that they're going to hearing from me. I am a father of two wonderful children, and my wife is a psychiatrist, and we basically made sure, both of us, that she was on no chemical whatsoever, including tea and coffee, throughout the pregnancy, because we wanted to make sure that we get a healthy child and we give a healthy, decent human being to the world. So the short answer is, if we can avoid all medications, that's the safest medication in pregnancy. The other idea about these categories of pregnancy, we all know that category A, B, C, D, etc. Everything is safe. It's almost like flying. You know that I'm about to take flight in about another 2 hours time to visit Sri Lanka to do some headache education missions also, while I'm going to see my parents at the same time. Any flight is safe as long as there's no plane crash. So the any medication is safe in pregnancy as long as it has not caused a problem. So those medications that we categorize as safe, they are relatively safe. They're not absolutely safe by any means. So we should try our very best, if at all possible, to avoid all medications during pregnancy. But I do understand that this is a really nasty disorder. While pregnancy generally give us a really nice honeymoon from migraine, there is a small percentage of patients who do get exacerbation of their headache. So we need to manage those the patients well. So what I normally do is I would look at pregnancy registry data at that time. I would do a quick literature search at that time with available data sources, then have a meaningful, engaging conversation with the patient in front of you to select relatively safe, preventative as well as acute medication at that time. I still strongly encourage using non-pharmacological electrical modulation, least side effect generating medications as much as possible if we have to use a medication. The good news is almost 95, 98, 99% of the pregnant women get a really good freedom from headaches during pregnancy, because you get a lot of steroid in your body we already alluded to the fact that there is a inflammatory subset in migraine patients, and that's probably one reason that they respond better. But if we have to use, we use the safest medications as the pregnancy registry data shown us at that particular time. Most of the new medications, we have zero data, as you could guess.
Yeah, of course. Well, thank you so much for your time today, Professor Wijeratne. That was so insightful. And I saw lots of fantastic comments and feedback throughout the presentation. So truly thank you so much for your time and answering all of our questions. That's it for Migraine and Headache Awareness Week this year. Thank you so much, everyone, for taking part, and thank you to all of our speakers. Yeah, it's been a wonderful week, and I hope to all see you in our community and for future events that we may host. Thank you so much, and goodbye.
Thank you so much for having me. And also a little invitation for all the participants. If any one of you wanted to have a nice holiday in majestic Sri Lanka in December, I am hosting the 10th Asian Regional Consortium of Headache on 18th of December. Sri Lanka is a cheap country to fly, and it's a really wonderful holiday destination. I'm strongly supported by Global, the Patient Advocacy Coalition, or GPAC, that is promoting better headache care worldwide, including the Migraine and Headache Australia also. So if any one of you, if you are capable of joining us, please join us. A meeting is targeted for medical practitioners, but we are going to have a section for people with lived experience also. We will open up an virtual arm also, and I'll share the link with you later on so that you can share it with the crowd later on. If you wanted to visit the website, which is which is in preparation at the moment, it is www.archhub.org, archhub.org. So that's in December.
Wonderful. Thank you so much. That sounds like a fantastic event. So hopefully some people are able to make it. I'll end the webinar, but thank you so much and have a lovely
Stay safe and well, everyone.
Okay, bye-bye.